Disproportionately, when we're talking about essential workers, we're talking about women of color.
The amount of stress that these pandemics have put on women healthcare workers is kind of unfathomable.
And so this intersection of race and gender, intersectionality, as Kimberly Crenshaw calls it, results in a disproportionate impact on women, particularly women of color and Black women within the criminal legal system.
Everyone, my name is Vibhu Krishna. I'm a third-year medical student at Columbia University in New York City. And during this pandemic, basically medical education got turned upside down. It was put on pause. Clinical rotation kind of dwindled off and became remote, and exam schedules became really iffy. And having studied visual arts in my undergraduate time at Vanderbilt, I wanted to find a way to amplify the voices of the amazing frontline workers, many of whom were my own mentors, many of whom were training me at the time during the rise of the pandemic. And as you probably know, New York City was a major epicenter of everything that was going on at the time. And so I created this platform called Faces of the Frontline, which is a website as well as a digital media campaign living on Instagram that serves to collect and share frontline stories. And the purpose of this is not only to capture what is happening in this extremely historical moment, but also to, in real time, drive awareness to the issues that frontline heroes are facing. And that includes, shortage of PPE, that includes anxiety confronting their working conditions, and it also includes difficulties balancing, increased demands at work, mental health, with increased demands at home as well. So I am really excited to be here and kind of do what I wanted to do with this platform in the first place, which is amplify the voices of our front lines and just draw attention to the issues that they face. With regards to this specific series, the idea here is to help uncover gaps in gender and potentially look at how Faces of the Frontline has actually been able to capture a little bit of that during the pandemic. And so I'll begin just by talking about my own experiences in the hospital. And I'll just say with the caveat that that's prior to the pandemic, so just as a medical student. And then talk through, how that has shifted and how female physicians have identified with various issues that are ongoing in the hospital throughout the course of the pandemic. And point to a few specific examples from the page. If you don't follow it, it's at Faces of the Frontline, so you should. And then I will just delve a little bit more deeply into what issues in general women in medicine are confronting. We'll point to some data towards that, and then we will discuss kind of now in the current context with the protests going on everywhere. Another pandemic is racism, and so what is the role now of our frontline? What is the frontline, and how do we as women kind of move forward and help to rebuild in the post-pandemic time? With that time referring to COVID. I want to start off with a quote by Kimberly Crenshaw from her paper, Mapping the Margins. And she basically says, cultural patterns of oppression are not only interrelated, but are bound together and influenced by overlapping systems of society. So I'll just leave that here for us to ponder and delve into kind of my own experience. So as a medical student and as a woman of color going through rotations in the hospital, and I think a lot of my female colleagues will commiserate with this, but sometimes you're just not heard. You're just not called on. You're in the room with a patient. Maybe you're even giving guidance to the patient or some sort of counseling or explaining, their discharge summary to them. And if there is a male in the room, the eye contact shifts to the male. And that can also mean, if there's a group of students and the attending physician asks a question, the male voice is more likely to just be picked up on as answering that correctly. Another kind of example that I think a lot of female students and physicians will relate to is kind of automatically being assumed to be involved in a different caretaking role. So whether you're called a nurse, an assistant, a young lady, sweetheart, any kind of other words, and that's not to say that it is by any means negative to be called a nurse or a PA, but it is just a different role that is being thrust upon you than what it is you are, whether it's a medical student or a practicing physician. So that's definitely, a thing that a lot of people experience. And it makes it really challenging when you're trying to give guidance and advice and you hope that it'll be taken seriously and taken back with the patient so that they can continue to follow whatever treatment regimen that they have been prescribed. And kind of seeing that like shift into the pandemic time. And again, I'll repeat, I was not in the hospital during the pandemic, but there were certain instances, just last week my building has a one person per elevator policy, and rightfully so, because around 1,000 people live in my building. So it'd be a very great way to spread COVID. I was, wearing my mask, walking to the elevator, and a man followed me in, and I was like, "Oh, excuse me, sir. There's a rule, one person per ride." He was like, "Oh, really?" And I was like, "Well, yes." And I said, "Yeah. So if you wouldn't mind, I'm happy to take the next one also, but or you can step out." He looked at me and said, "Don't tell me what to do, girl." And then proceeded to explain to me that he was an engineer and had a very good grasp of the situation, and asked me what I did. And I said I was a medical student, my third year, and that the recommendations and the public health guidelines on top of the building rules were to wear a face covering and to have one person per elevator ride. He got very upset and didn't leave the elevator, and then eventually kind of huffed off. And I thought that was a great example of just like your everyday sort of sexism in which you're just not taken seriously. And I think I could have been wearing scrubs and a white coat and it would have been the same. And I mention that because a physician that we actually featured on Faces of the Frontline, Dr. Sneha Topke, had a similar experience in which she was going for a run in New York City, and someone was not wearing a mask and I think was either sneezing or coughing on the sidewalk. And she wrote a diary entry about how she just kind of stopped and told them politely to wear a mask, and they just started cussing her out. And so, like, and you can say, "Oh, I'm a doctor," and you can say, like, "This is my medical advice." And even if you're not a doctor and you are just, a citizen saying this because it is the guideline and it is the rule in New York City, you're just not always going to be taken seriously. And there will be people who are accustomed to holding the power in these sorts of circumstances who will simply not listen to you just because of how you look and how you sound. Of course, that can be frustrating. And I can only imagine what that's like inside the hospital walls, where you are maybe giving a patient advice and it's just not taken seriously, or you're giving them a guidance and and I'm not saying that sexism exists only, between the doctor and patient. And of course, among healthcare workers, of all kind of walks. And that kind of brings me to the story of Dr. Edna, another physician that we featured on Faces of the Frontline and who I was able to actually interview for quite some time. And Edna is a Black physician. And as you can imagine, during this time, she has faced unique issues just being a Black woman in medicine at the front lines of the two ongoing pandemics. And she was extremely brave in sharing her story with us. And one thing that she said that stood out quite strongly for me was, "My white coat does not protect me." And I think what she meant by that is, you can be like wearing it all. You can have your clipboard, your prescription, your like team around you and be guiding the conversation. And it is still a struggle to hold that space. Simply because you are a woman. And then if you are a woman of color, and even further, if you are a Black woman, the challenges that you face are unique. And yet, in calling back on the Kimberly Crenshaw quote that I read at the beginning, are extremely overlapping. So these are all like intersectional issues that have infiltrated medicine basically since the advent of Western medicine. When you think about that, those challenges that you're facing, on top of just the general anxiety and stress of seeing so much death, seeing a new disease all around you, being worked kind of to the brink of burnout or even beyond burnout in many cases. Plus, if you have children at home, and you are suddenly also responsible for their virtual and homeschooling, the amount of stress that these pandemics have put on women healthcare workers is kind of unfathomable. I think about Dr. Rosendahl is a cardiologist in the New York City area, and she was able to share her story with us as well about, having kids and having to navigate a very steep increase in the demands of her job with a very steep increase in the demands of motherhood, which included education. Even though now about 50% of new graduate medical students, or like students who are in training to become physicians, are women. Unfortunately, women still end up, the domestic division of labor in terms of, housekeeping and taking care of kids, etc., has not shifted to account for that. So women physicians end up having to do a lot of the domestic duties that they might have done otherwise if, they were staying at home. And that just increases the stress because you're responsible for so many more things than your male counterparts. In the 60s, around 1966, less than 10% of graduating medical students were women. So as I mentioned, now it's around half. And so slowly we'll be correcting this imbalance. I think it was in 2017 where nationally 1/3, and I'm talking about nationally as in the US, 1/3 of practicing physicians were women. So now that like the trainees are 50%, slowly we'll be kind of expanding that number to have more representation in medicine. But unfortunately, just the representation is certainly, that will help. It helps when, as a student, I walk in and I see someone that looks like me in a position that I, aspire to be in, or simply holding their ground, which is a feat in and of itself. But there's a lot of work to be done, even beyond representation. And so one of those things is just the wage gap in general. It's absolutely horrendous in medicine. There was a study in JAMA that was published, and it surveyed 24 US public medical centers and found, and this is adjusting for years and experience and age and hours, etc. It still found a $19,878 wage gap between male and female physicians. And I mean, that's mind-boggling to me as someone who, will be entering this field. And similarly, a landmark report in 2019 by Medscape kind of also reiterated this gap, and also said that this gap occurs in an intersectional fashion, with race, of course, being involved. So cue the Kimberly Crenshaw quote again. The Medscape report found that white physicians make an average of $319,000 per year. Latinx physicians, $303,000. Asian physicians, $300,000. And Black physicians, $281,000 per year. So from 319 white physicians to 281 Black physicians, there is an obvious gap here. And again, this is controlling for a lot of variables. And so we have to ask ourselves, why is this? Why is this happening? And the first thing is, well, a lot of programs, have people who trained in the older days and have old white men in positions of power. So women are much less likely to hold leadership positions, departmental chair positions. They're much less likely to rise to the ranks of like associate professor or full professorship. And then they are also more likely to be volunteered for work. So whether it's leading some kind of committee, engaging in some kind of teaching position, they maybe will be pushed towards doing that, but will be expected to do it pro bono. And there's another aspect of it, which is systemic, and this one I don't have data for you for, but I can speak to like anecdotal evidence, which is like if I'm training and I'm in maybe like the psychiatry or OBGYN rotation, and I see so many women, and in fact, so many women of color doing these jobs, I can see myself there. And so maybe I'm more likely to go there. Whereas if I'm rotating, for example, in orthopedic surgery, which historically just has a lot more men than women, I might not feel at home among that group of people, and I might not be made to feel at home either. And so I might be less likely to choose that as a student. And so as it turns out, in general, women tend to be placed in more programs that tend to be less specialized and lower paying. And so it perpetuates this cycle in that way. And I remember reading this piece, We Shall Be Feminists by Adichie, and she talks about how like she was wanting to be a hall monitor, but she'd never seen someone who looked like her in that position, and so she just didn't go for it. And that happens, that kind of just like psychological phenomenon, whether we're aware of it or not. If we don't see, or if we're not able to visualize ourselves there, I mean, it's really hard to put yourself there and bring yourself there and seek the mentorship and advice and guidance and whatever negotiations, whether that's salary negotiations or working hour negotiations so you can have childcare, etc. It's really hard to get there. And I am lucky in my childhood to have my mom, who is a pediatrician and a frontline worker who has also been featured on Faces of the Frontlines. And I've been able to see how she, as a physician of color, immigrated from India and worked her way up to be where she is now, at the career she wants. But even she was telling me just last night, like, it took her decades to get to this point where she is able to be paid for her teaching work, and she's able to split her time in a way where she is accounting for all of the hours in those sort of committee and teaching engagements that I had mentioned are often thrust onto women as pro bono work. And she has never complained about her job, and she works at a very wonderful hospital that definitely treats her well. And that is, an astounding kind of thing that I've been able to see and have been able to engage with in terms of looking at her as a role model. But even for her, it took years to even reach at this point where she could work at this hospital and be taken seriously and respected and be called upon to lead these various things. And I guess, this kind of leads me to this point of mental health and balance and training. And when we're looking at residents and we're in training and trying to find role models and kind of place our own goals and objectives into these categories and figure out where we belong, there was a study that was rewritten up in the New York Times by Drew Culler in 2017. And it was a survey of 3,100 newly minted doctors. And prior to residency, they came in all with similar depression kind of symptoms and tendencies and rates. As residency goes on, the rates of depression increase basically among everyone. This is, another thing to add to our intersectional dialogue here, which is the mental health of our residents. And in light of, the Dr. Breen's suicide, the ER doctor in New York City, I think it's important to note just how much these, residency programs and then going on to become a physician and facing various barriers can lead to your own demise, really. But this study showed that the depressive symptoms increased in both groups, but increased significantly more in women doctors. And the study gave a few reasons for this, but one of them was the increasing demands from their job and, the domestic kind of conflicts that ensued. So the inability to kind of keep up with this sort of unfair quantity of domestic and household sort of work alongside their rise in their career. And I don't know how my mom did it. I can't imagine how challenging it was to be navigating an entirely new healthcare system with young children. And I don't know how Dr. Rosenell did it and is doing it. And I don't know how many people are coping with this and getting the support that they need. But I do know that it is something that we need to keep talking about. And it is something that we need to draw awareness to, because there are so many places in which there is assistance needed and various ways in which hospital systems need to take care of their staff to prevent the loss of their workforce. And that includes, I say, Dr. Breen as a casualty of this pandemic. I mean, she faced innumerable stressors as an ER doctor in New York City, working so many long hours. And, I can't say for sure, and it is impossible to know, but I would imagine that her, being a woman contributed in some way to the mental health kind of state that she was in towards the end. And it's an extremely difficult topic, and it is ever more important in light of the Black Lives Matter revolution and protests that are sweeping various countries internationally. And it's because of what I said. This is all intersectional. It is, the opportunities that are presented to people who look a certain way. These are all part of the same kind of systems. And so how do we address this moving forward, I guess, is, where's the hope? I just said a lot of things that are really intense and perhaps are new knowledge to you if you're watching this. And there are a few ways that we can work on this. So one is awareness, and that's where platforms like Faces of the Frontline, storytelling platforms, giving people a voice is one thing. And I think that's the first step. We have to build awareness around an issue. And in parallel to that, really, we have to be thinking of how these structures can be adapted. So we need to make a kind of list of specific ways in which institutions can make sustainable change. And I mean, that means having institutions survey their own staff members and, actually listen to what it is they have to say and what challenges that they are facing, and then equip them with the right resources to address them. So whether that's making lactation rooms more available in the hospital, whether that's having better childcare support, whether that is in the training for residencies when they are teaching medical students to make them aware of the various issues that female medical students might face, making sure that they're given ample opportunity to talk and prove themselves, or, allowing them to, introducing the student to the patient and saying, this is a medical student, instead of, letting the patient assume who the person is. And there's that like kind of micro level, and then there's the macro level in which hospitals also adhere to better data transparency. Maybe they should have to publish the wages that they are giving their staff, and actually do some deep introspection and do an internal audit of the salaries that are being given and why, and then adjust for the confounding factors mentioned, among others that I'm sure exist that are beyond my pay grade. I think data transparency is certainly something that needs to happen in order to create that change. And of course, then there's a societal level, and that means organizations who are working to support our women of color, our Black women, and making sure that the resources that they need are given to them, and are available to them. I could go on for a long time on this, but I also just want to add here, I spoke mostly on one end of things. I am speaking for myself as a medical student, and then from some research and the stories of physicians on the front line that I have been able to amass. But of course, these inequalities and inequities exist among patients, patient access to resources, patient access to physicians, the way in which patients are treated by physicians. And so this racism and sexism exists across basically any aspect of medicine that you can come up with. It exists. And so, while I have this, one perspective to share, the work needs to be done and shared by many. And I think, that again, it starts with awareness. It starts with listening and paying attention, which is hard because there is so much to pay attention to right now. But we have to start doing the work. And I think there is hope. I mean, if seeing just the rise in the number of women physicians is, one thing that's a positive. And there's a lot of work to be done. There's a lot of leadership and giving, women physicians and all healthcare workers, really equipping them with the resources to make changes, learning how to negotiate their salaries, knowing how to kind of develop certain leadership skills that maybe they were denied access to in the past or simply could not visualize themselves fulfilling, and keeping track of hours that they're spending on work, and making sure they're compensated fairly for those hours, making sure that referrals are, divvied up in a way that is fair. And so there's a lot of ways in which we can address this. And I think building awareness is certainly one, and it's one of very, very many. So that's basically all I had to say. I really hope that this was informative in some way, and that it inspires anyone who watches this to take whatever step it is, whether it's reading a few stories, educating yourself, or it is encouraging or starting a petition at your hospital to demand wage transparency. I mean, there are so many levels at which this can go, and I think that's just one other hope to end on, which is that when there are so many rooms for improvement, there's so much space for improvement, it's not that hard to start improving, because there's just, any amount will make a difference. So I encourage everyone to take those steps. And I really thank you so much for your time.